HIEM. So and say hello to everybody. So it's nice to meet you again. So today's class is actually requested by Dr. Prakash. Thank you for giving me this opportunity. So Chitwan Medical College is located centrally in Nepal, where many patients come directly or referred from different hospitals for the management of many diseases. One of the frequently encountered disease is poisoning. So once again, good morning and namaste to everybody and Caesar and HIEM batches. And thank you, Mr. Boone. Is he here for class?
Yeah, he is here. Yeah.
Okay, for contacting me and the time management for today's session. So so myself, Dr. Daya, Lamsal. So again, happy to be here with you in today's session. For the international friend, this is a nice flag of Nepal. So having moon and sun inside. And so Nepal is located between big two countries, North Tibet and South India. So the Indian capital is not so far from Nepal. So only this is just the background, and today's objective is to share and discuss about common poisoning cases reported to Chitwan Medical College. I'm confined to this hospitals cases. It's not in detail, but just a briefing what we see in everyday clinical practice. Most of our HIEM residents already know it, but it will be just a reminder for them. And for those international training residents from outside, may be new for these epidemiological trends. This is just a background. So I have included here. So it's approximately 200 patients report to emergency department each year, and deliberate self-harm is the main motive behind. So this is not an accidental incident. We see drug overdose skipped for their treatment or some other family members' treatment, they accidentally took it. But most of the occasion, deliberate self-harm is the main motive behind. And pesticide, one of the common insecticides used in for farming by the farmer to control their pest is the most common chemical agent found to be the cause. And psychiatric comorbidity, which may be missed in the initial evaluation, is the most important treatment for the early diagnosis and treatment for the subsequent recurrence of such event in future. In a rural setup, sometimes we get patients from rural community and rural hospital. The hospital setup has minimal resources, minimally trained doctor. Sometimes this proper specific antidote may not be available, even pralidoxim. The mortality rate rises high in such settings. So the fatality by organophosphate may reach up to 15 to 30%, according to data from India, which is Indian hospital which has a similar circumstances like ours. This is one of the rural treatment offered in Sri Lanka due to organophosphate poisoning. Chitwan Medical College, I just reviewed few data. It's a 12 months data. This is a real data of Chitwan Medical College. It's of last 12 months. The most common poisoning is organophosphate. It comprises 60 out of 192 patients. The second one is household chemicals, cleaning chemicals is around 33%, 33 cases. If you combine both organophosphate and other insecticides, it tops again the rank is almost in third, other than the organophosphate and carbamates, 29. Drug overdose constitutes fourth most common. The paracetamol, olanzapine, nitrous oxide chemical is clonazepam, gamma benzene hexachloride, benzodiazepines, and difenoconazole, tricyclic antidepressant, carbamazepine, mefenamic, and iron are the few drugs which has been included in this drug overdose group. Rodenticide is used by the farmers to kill, and the house wives mainly to kill rats, mainly in kitchen and other garden, around the garden. It's constituted as 18. This chemical composition of rodenticide is zinc and aluminum phosphide. Herbal plants and mushroom, as plants like mushroom constitute this 11. So miscellaneous and other unknown poisons are 8. Acid and alkali, say coming down in the list. 4. Kerosene is even less. 3. And alcohol intoxication rate. Out of them, one poison which was not identified died within hours in emergency. The substance was not identified. They said he was ingested a poison, but the final diagnosis was not made, and the patient was sent for postmortem study, and we do not get the report of postmortem study because it is done in government hospital, and generally they do not give us the final report. When we talk about poisoning in our context, is almost universally pesticide and containing organophosphate unless otherwise, because it's very toxic and fatal. So we immediately want to rule out organophosphate compound because it is most commonly used as by the patient as a means of deliberate self-poison. And the motive behind is suicide. About 24% of patients take this poison by the motive of suicidal attempt, with the intent of suicidal attempt. In our neighboring another country, in Bangladesh, the organophosphate compound comprises of 66.1% of total poisoning agent. Our friends, it's HIEM training, they must have seen so many patients in emergency department and even ICU in critical areas. So most of the patients come with the brand name, and our main aim is to identify whether the brands constitute the organophosphate or not. So our immediate aim is to stabilize the patient and later to identify the chemical composition containing this insecticide, whether it is whether it contains organophosphate compound or not, or the similar property or similar symptoms of patients who may present with carbamate poisoning may have similar presentation in the beginning, which is almost difficult to differentiate between the organophosphate and carbamate. The organophosphate poisoning are widely used as an insecticide, and patient can die as a result of acute cholinergic syndrome. It's a combination of syndrome which results in a CNS as muscarinic and nicotinic manifestations. OP compounds are widely used for agricultural domestic pest control and as a NOR agent, as in warfare. Pesticide self-poisoning occurs on 6 to 1/8 of all suicide and a third of suicidal death in rural Asia each year. Toxicity generally results from intentional inhalation, occasionally accidental during in the field during spray, where they may neglect during exposure due to inadequate training in our setup. OP are observed through skin, mucous membrane, and gut. According to our hospital report, most of the patients they drink, they ingest orally, and the significant amount of the liquid poison goes to their stomach and absorbed from the intestinal tract. Muscle-based studies in Nepal revealed OP compounds is the most common. As I already said, it may comprise up to 25% study in some other uh, uh, study conducted in the different parts of our hospital. And worldwide, it is one of the most important cause of mortality and morbidity. But in developed country like US, the number is significantly low and the death is very few. Organophosphate inhibits cholinesterase, causing accumulation of acetylcholine at nerve endings and neuromuscular junction. It irreversibly binds the cholinesterase, which is called aging, and it takes some minutes to hours to develop aging. And our main aim is to start specific antidote before the aging occurs. So the time of inhalation and reaching to hospital to start the specific antidote is very important. Pralidoxin reactivates cholinesterase if given promptly. So carbamate insecticides act similarly to UP, but the poisoning with carbamates is generally less severe and pralidoxin is not needed. This is so how the organophosphate acts in the neuromuscular junction. This is a normal pathological pathophysiological process. Acetylcholine signals passes to the postsynaptic neuromuscular cells. So acetylcholinesterase stops signaling process and it inhibits the acetylcholinesterase in the neuromuscular junction. So organophosphate binds cholinesterase and prevent breakdown of cholinesterase, acetylcholine. It manifests in severe toxicity as a sympathetic and parasympathetic activity. Like it's one of the common toxidome which we frequently remember to assess the patient quickly on the basis of clinical presentation, dumbbells, diarrhea, urination, meiosis, bradycardia, bronchospasm, emesis, lacrimation, lethargy, salivation, and seizure. These are the groups of syndromes, and it is almost diagnostic when we see the group of symptoms in a patient who gives a history of inhalation of some poison, even if it's not properly remembered or labeled, or the quantity has not been found. In such situations, such toxidomes helps a lot for in the initial diagnosis of the organophosphate poisoning. Slush is another the toxidome used to detect like salivation, lacrimation, urination, diarrhea, GI cramps, and emesis. The specific drug for this poisoning are the atropine and pralidoxin. Before starting this treatment, we always have to monitor the patient immediately when reached to the emergency department, starting from A, B, C, D, E. Airway may be compromised due to excessive secretion or vomiting. There is a high risk of aspiration due to these cholinergic symptoms. In such condition, we have to maintain the airway and protect the airway from aspiration by securing airway by endotracheal intubation in severely toxic patient, and we will start the antidote as early as possible after initial ABCDE management. Depends upon the OP organophosphate agents, the acetyl inhibition, the route of absorption and enzymatic conversion, the active metabolites and the lipophilicity of the OP agents as the manifestation depends on the amount and the process of absorption. So as I already told, these symptoms are is commonly grouped into muscarinic, nicotinic, and CNS manifestation. These manifestations I have already explained in the previous slide. So nicotinic symptoms have twitching, fasciculation, and cramps, and flaccid paralysis of limb muscles, and decreased tendon reflexes due to nicotinic effect. And CNS effect is one of the very much prominent and is easily detectable when patients presents with a very toxic inhalation or exposure. Anxiety, restlessness, dizziness, vomiting, confusion are the common, and as the severity increases or the patients present with very severe symptoms, neuroparalysis, even patients develops coma, convulsion, and even patient may die during the course of resuscitation if it is heavily intoxicated. Neurointermediate syndrome is a syndrome where the patient develops a neck flexion weakness and decreased tendon reflexes, cranial nerve pulses, and after 24 to 46, 96 hours of treatment. So it is one of the common, one of the important syndrome which we have to look during the follow-up. Especially, it is important for the doctors who are working in ICU or in observation of emergency department. We generally admit the patient within 24 hours, within 25, mostly within hours, not up to 24 hours, but it is important for us if we have to follow up this patient in critical care unit revision. The delayed and long-term neuropathy, we generally do not notice such symptoms in emergency department, but for the public health point of view, or for the doctors who see such patients in OPD, these type of patients may present late, even after improved from and discharged from the hospital. They may present with the neuropathy in medical or in a general practice OPD. So diagnosis mainly is based on the toxidomes, but as far as the lab is concerned, in Chiton College we have acetylcholinesterase analysis facility in our university lab, which is measured in serum. And before asking for this blood investigation, we can monitor the patients by looking whether the patient is developing acidosis or metabolic acidosis, or patient may have developed some arrhythmia like bradycardia, or even this patient may be posed with the hypoxia. Such things has to be continuously monitored and secured. Oxygen, blood pressure, and arrhythmia has to be treated first before this specific test has to be sent as a part of laboratory evaluation. For the specific treatment, the atropine 1 gram probably is a trial, but we don't start this for the confirmed case or highly suspected case. We give atropine 2 mg and review the patients every 5 minutes, and we keep on adding the dose until we get desired effect of adequate atropinization. This is as a part of initial management, ABCD, as I had already told. use gastric lavage is a controversial if it is beneficial if it is present within 1 hour of inhalation, or severely toxic patient in coma or convulsion. It's very difficult to get gastric lavage without securing the airway. So decontamination is one of the important measures. Before the patient is received in the emergency department, if the patient is stable, we ask immediate decontamination. If the patient is in very critical condition, we keep on monitor and decontaminate the patient as a part during the part of the resuscitation. Specific management, as I have already told you, is the atropine is the main antidote for muscarinic symptoms. It decreases secretion, it clears airways, and improves patient's oxygenation. And for clinical assessment, if the airway is clear, that is one of the endpoint of our treatment goal of atropine, is organophosphate poisoning. So apart from the clearance of airway, the blood pressure should improve, and the heart pulse rate is expected to be above 90 in some of the guideline. So it should be above 80, or there should be decreased bronchuria and bronchospasm. So that is the indication of adequate atropinization. The oxime, a pralidoxime, is reactive acetyl cholinesterase, and it's recommended to start preferably within 6 hours of inhalation, but it can be given up to 12 hours in a dose of 30 mg per kg bolus dosage, or it can be given as an infusion at a rate of 80 mg per kg body weight. The another group of poison which we found in our setup is rodenticide or rat poison, because it's rat poison. Rats are actually in our ecosystem is rats is found in our habitat around home. So it's it annoys people because it disturbs foods, and or it's economically it's very very harmful animal for farmer, and farmer tend to kill rats to protect to protect their crops and grains. So the rodenticide is available in Nepalese market easily, and the regulation is not so strict that people might get rat poison easily when they tend to buy from the veterinary shops. So it is used to kill rodents, mice, squirrels, and the chemical composition mostly involves this long-acting superafferent anticoagulants, and the clinical categorization of rodents it utilizes the amount of poison that cause lethal, cause death in 50% of the following exposure, what we call lethal dose or LD50. So if the LD50 is 10 0 to 50 mg per kg, it is highly toxic, and in the label it is labeled as is now it is labeled as danger, and if it is toxic, LD50 is 50 to 500 mg per kg is a warning, and the less toxic is if the LD50 is 500 to 5000 mg per kg, it is labeled as caution. This epidemiology, it accounts about 0.5%, approximately 2.3 million human exposure repeated annually in the poison center in US. But in Nepal, it's one of the second, sometimes in some studies it's second, or some studies third important cause of poison reported in different hospitals of emergency in our part. When aluminum comes in contact with acid in the stomach, it liberates oxygen gas and inhibits cytochrome oxidase. which causes widespread cellular hypoxia and metabolic acidosis. It may involve multiple organs, particularly lungs, heart. In heart, it causes myocarditis and arrhythmia, cardiac failure. The clinical features of rodenticides are mostly it causes GI disturbances like nausea, vomiting, retrostational and chest pain, burning sensation, and abdominal pain, breathlessness due to ARDS, and cardiac manifestation. Cardiac manifestation presents with hypotension, arrhythmia, bradycardia, at EF, or ventricular arrhythmia. Acidotic breathing is due to metabolic acidosis. The management is a non-specific and supportive care is mainly the supportive care, respiratory, cardiovascular, and gastric lavage with potassium permanganate or coconut oil prevent fossil gas. But this coconut oil is preferred, but it is not always easily available. Sometimes gastric lavage, the role of gastric lavage is controversial because due to liberation of fossil gas production. Activated charcoal to observe if it is present on early stage may be helpful. The magnesium sulfate is the antiperioxidant, anti-arrhythmic and membrane stabilizing effect may be useful. Arrhythmia. Yeah. The next one is the next group is drugs. We have seen many patients presenting with the drug overdose. But if you see the data as compared to the Western literature, the drug overdose is less common in our heart. But the paracetamol poisoning, we frequently see paracetamol poisoning in our hospital. So paracetamol is easily available in over the counter. And particularly children which are being frequently treated for fever at home with your mother may get accidental poisoning and death, but it may be used by the adult as a part of deliberate self-harm. The toxic dose is adult is 150 mg per kg as total on 7.5 gram of weight regardless of weight. So the physiology is the most important thing is this paracetamol active metabolite, the N-acetylic benzoquinone imine is binds with glutathione in the liver and causes hepatic necrosis. But it takes time. The most important thing is the patient, when patient present to emergency department, patient may not get such pathological changes or symptoms at the time of initial presentation. So it is very important to see the drug level if the facility is available and to observe the patient even the patients have minimal symptoms. The patient may develop the severe toxicity later on. So this is the pathophysiology which I have already mentioned. The clinical feature is abdominal pain, vomiting, and abdominal discomfort, which may be present within few hours of ingestion. But the patient left untreated, the patient may develop liver damage, vomiting continues beyond 12 hours, or there is pain and tenderness in the liver for up to 24 hours. Jaundice develops later on, even after 40 hours to 72 hours, and the patient may develop coma from hypoglycemia and hepatic encephalopathy later on due to the acute fulminant hepatic failure. This is the normogram which we plot according to the drug level, and we decide whether we start any system or not. So these are on this normogram plotting. So this is the serum concentration of paracetamol in the blood, and this is our ingestion since and ingestion. So in the initial phase, even the patient has ingested, it may not be detected. So we have to repeat. It's ideally it has to be sent on 4th hour of ingestion, and as the time passes on, this drug level tends to decline. Some of the drugs, drug level screening facility is available in our hospital. Apart from paracetamol, these are the few drug level which can be done in emergency department. Say acetaminophen is here, the blood serum is sent, and we expect we get the report within 2 hours of test. Some other drugs which can be associated with paracetamol, like ethanol. This ethanol and may be used by the patients with any poisoning, like organophosphate insecticide or any drugs. The ethanol may be mixed or combined with the other drugs or poison. So this ethanol screening facility is available in our hospital. As I explained in our previous slide, the phenytoin overdose, carbamazepine, and lithium toxicity is also presented in our cases. So this drug level facility and drug level facility is available in our laboratories. So other than these other drugs, benzodiazepines like opiates, even carbamazepine is cannabinoids is common in Shivaratri festival in Nepal culture, where this especially the teenagers and the young try to get the pleasant effect of marijuana, and these marijuana or cannabinoid toxicity may present in our emergency department during this festival. So we have reported 8 patients in one, I think it's 6 years back. The 8 children presented in a group from in nearby district after the consumption of marijuana and dhatura is a poisoning in a festival which they ingested for the purpose of entertainment. Is that this management of paracetamol poisoning is the gastrointestinal decontamination with activated charcoal in the dose of 1 mg per gram. So by mouth, all patients present within 4 hours of ingestion. Antidote is any style system administered within 8 hours following acetaminophen overdose. This we follow different protocol, but 20-hour IV protocol is usually is recommended. It's a loading dose is 150 mg per kg IV over 15 to 60 minutes, and 50 mg per kg is given in next 4 hours. Then 12.5 mg per kg per hour for next 4 hours, and finally 100 mg per kg over 16 hours. So this treatment protocol provides a total of 300 mg per kg over 20 to 21 hours. Any style system treatment should be stopped if the patient fulfills all of the 3 of the following conditions. If the patient is asymptomatic, acetaminophen concentration is not detectable, and serum transaminase activity is decreasing significantly. So we have to periodically monitor the serum transaminase to detect the severity of liver toxicity. Liver transplant is available in CMC, but we have not offered it for any patients with acute liver failure. So the option is now available in our setup. But whether the patient will fit or the donor is available at the time is very difficult to say. For any type of poison, we can get help of Nepal Drug and Poison Information Center. The center is located in Kathmandu, not in Chittagong. It's a phone number and website. Dr. Lohani is very active to establish this center. He is supporting this Nepal Drug Poison Center for years, and I had invited him to give a lecture note few years back, with many residents and paramedics attended this seminar, and we can get help of this telephone whenever we need, and it opens 24 hours. Actually, we may have some role in prevention and control of such toxic compounds. The government is trying to bring act in Nepal to control the very hazardous pesticides. And so when we advocate the control of very toxic poisons in our community, that may ultimately help the persons getting such a very toxic exposure, especially the accidental exposure. And our farmers has to be trained for proper spraying, and the children has to be advised to keep the drugs away from their reach, and the farmers has to be trained for proper spray in the farming. It's not our responsibility, but we can help them, we can advise them at the time of discharge. The most important thing is to get a psychiatric consultation, psychiatric assessment, because such patient may be neglected in the community, and the patient may attempt second time to commit suicide. So our role is in emergency to get access to the psychiatric consultation and follow the protocol to save the patients from unfortunate complications and mortality. These are few references. Thank you. If you have any queries, I'll try to answer it. But I am not the toxicologist. I have not much past experience. But this is what I want to share in today's class. Sikandar, you are
Hello, sir. Hello.
Hello.
Sir. Like it's feeling very good. Very nice to see you. So from here to there, and that place is one of my favorite place of in Chennai. This I can imagine how you can imagine how I'm feeling happy to see you all guys in that room. I was there for last 1 year. And like one more thing I would like to add.
Ask you each and everybody, but can I call your name? Sikandar, Sundar, Saurabh, Suchit, Prajwal, Rosina.
Namaste, sir.
Namaste. Hello, everybody. So,
Prof, hi, Prof. It's Dr. Alam. I'm here. I think one thing I must appreciate these all guys. They're very, very good lads, and very well behaved. They are making a very, very good progress. I think the credit should go to yourself as well for that.
Yeah. So, hi, Professor. So,
hello.
Hello. My name is Mr. Janu. I'm an ED consultant. So, I will add something in your paracetamol overdose. What the difference in the practice is in the UK and in your country. I think first is a beautiful presentation, and it's really amazing that how we speak common language and common set of treatment globally. That's the beauty of the medicine. Now here we have transferred to 12-hour treatment now. So what we do is we give first dose over 1 hour, the N-acetylcysteine, and the second dose we give over 12 hours. So we finish over 12 hours, because this is a bit better for NHS as well, because the time spent in the hospital is reduced by 12 hours. And you're absolutely right. At the end of the 12 hours, we repeat blood test, and then we have the psychiatry assessment. I wonder whether you would like to change practice in your hospital as well, because probably over a short span of period treatment would be better. People can go to their family and it might have economic impact on the family as well over there.
Yeah. Mostly the family member accompany with the patients, and we have to counsel because they are in stress, because they are the family member are in very sick condition, and most of the time it is unexpected. So it is obvious that they are in stress, and we have to counsel the patients, and we have to explain the expected course in hospital.
So my point is that if we move to 12 hours, the stay in the hospital might reduce, and you will have a more bed available for other patient. The resources will be more to treat other patients. So we follow here 12-hour treatment nowadays
Okay.
in the UK.
It's better regimen.
I think, Mr. Lee,
Dr.
probably
Sir?
over here the push is 12 hours. Probably it's just because you got a long bed wait and all that. I don't know. I'm not. I'm not sure how is the situation back home, in Nepal. Whether there is a push for a bed.
No, it's not a push. It's evidence-based now. There's no difference whether we treat over 24 hours, 12 hours. There's no difference. So the treatment goal are the same. So that's why we moved to 12 hours treatment in the UK. I don't think so the bed push is, behind this research. And now we have changed our practice to 12-hour treatment rather than 24-hour treatment across all NHS organization.
Sure.
Because back home, I know, because I come from Pakistan, from Punjab, people are poor. They're mostly the private sort of organization. So I think, I don't know what professor think, if they move to 12-hour treatment, so it might well be economic benefit to the family of
it is maybe updated, and we can start this regimen here too. So I think it's better, and it's updated. So
yeah, you're right. It's might be your community might be better off, because I understand there's in Punjab, Pakistan, surely the private hospitals are quite a bit of expensive, and so government hospitals still not very people, the doctor there, my colleague, they do rather more of a private practice rather than work in the government hospital. So they've made their own hospital. So if we start 12-hour treatment, it might well be an economic benefit to the families as well, because these families are mostly poor families, psychiatric problem, disjointed family, disrupted families as here in advanced world as well. So I think probably moving to 12 hours might be, good for the community over there. But certainly I normally advise, back home to my colleague who are working there, I convince them to go on that sort of 12-hour treatment. And most of my colleagues have moved to 12-hour treatment back home as well.
thank you, sir.
Just a bit of thought that the research here has shown that there's no difference between 12 and 24-hour treatment.
Thank you, Mr. Junjua. But the main thing is the patient can get benefit with their economical conditions. Definitely, if you start a 12-hour treatment. But the best thing about the CMC, ED and CMC is in the ED, 0-hour waiting, and there is no problem for bed.
Yeah.
So, in my point of view, the patient can get benefit for.
Their people have to work, is it? Here they throw sickie and come to ED and sit there for 24 hours.
Exactly.
There are a lot of difference between economic condition and the work pattern. But I think I must say that the people are great there. The way they are working, a difficult situation, everything. Because I've been working back home as well, so I understand how difficult it is to work around rural areas, these sort of stuff, and far-fetched communities. So I absolutely understand, fully appreciate the contribution they are making and the contribution you guys are going to make when you will go back home. I think you are in I would say blessed position, really. So you are the chosen people, quite frankly.
Thank you, Mr. Z. Olu, do you like to add something?
Thank you very much, Prof. That was very, very, very educative. And it's just I really appreciate your detailed explanation of the organophosphate poisoning. I know we might say we don't see a lot here, but when you see it, you don't want to be caught off foot. And like you said, you know, the problem we might have here is when we see organophosphate poisoning here, we might be thinking of pyridoxine, and we might be searching everywhere for pyridoxine. But like you said, sir, the first treatment is to give them what do you call it, atropine. So, and you know, titrate the dose until you see a good response. So, I mean, a good learning point for all of us here is we do know pyridoxine is the treatment for organophosphate, but the first thing you want to give is symptomatic improvement and atropine. Give a lot of atropine and make sure that the heart, not just the heart rate, there's no bronchial wetness, the respiratory rate is fine, there's no wetness. So thank you so much for reminding us, for telling us that. So point of important point, although in exam, if they ask us what is the treatment of choice for organophosphate poisoning, the answer is pyridoxine. But Amitav will bear me witness here in the exam. They will give you, they might ask you what is the first drug you will give a patient with organophosphate poison. They will put atropine until good response. They might put pyridoxine. You see, that exam is so terrible. So both answers are correct, but you will want to give atropine first. But if they say what is the definite treatment, the answer, like the prof said, is pyridoxine. However, what if this patient has been poisoned more than 48 hours? Like the prof said, pyridoxine has to be given quickly. But a patient that has been poisoned more than 48 hours, pyridoxine will not have an effect again because that anticholinesterase binding has been permanent. Yeah, so thank you so much. I really appreciate that, Prof. Thanks.
I think the lag period is 12 hours, is it? If you give pyridoxine within 12 hours, so it's a bit effective. 12 hours past, then you have to intubate, and you know, people might be intubated for quite a lengthy period of time because of the generation of the cholinesterase. I think in our practice here, we might see the mild site of poisoning, not the severe poisoning, which you know, we see back home. And the mild site of poisoning, I mean, there might be a little bit salivation and stuff, but the most common is like, you know, some sort of paresthesia. And here our gut reaction is always what their disease called, which is ascending paralysis, what that Guillain-Barré syndrome or something like that. I think, you know, when some sort of people come with that sort of paresthesia, thing like that. So I think the question to ask is whether that patient has been to the greenhouse or something. You know, I think that's a pertinent question in our practice. But here people don't. I mean, back home, it's a bit of psychological difference, as Professor is saying. Back home, paracetamol is not a drug of choice to poison themselves, because the concept is that the tablets, the Western tablets contain goodness. They don't kill you. Okay, so they don't take paracetamol. Believe me, because it's the paracetamol they take to get better. They don't take to get killed them. But they know that pesticide and organophosphorus will kill you. So that's why they take that overdose. I think there's a bit of psychological impact.
And availability.
Yeah, you're right.
And the other thing is most of them are, you know, agricultural background. So it is freely available when they are under stress. It is available anytime, isn't it?
Yeah, you're right. Yeah, and the gender distribution mostly is the women, especially young women who kill themselves. It's a heartbreaking, you know. I mean, you know, so a lot of stories.
Yeah. So apart from this organophosphate drug, in Nepal, one of the festival which is celebrated in our part, particularly in our region. So the people used to taste a recreational drug like marriage. The marijuana is free on that day. It's a limited amount. Sometimes these toxicity, is a inhalation of marijuana. It's smoking of marijuana. This is not inhalation. It's smoking of marijuana is one of the compound that is frequently found on that day, particular day. And they might taste a dhatura. It's a alkaloids. This belladonna alkaloids is the seed is grinded and they drink with the water or sometimes milk. Especially the teenagers want to taste it. This in this festival I got 6 children who had agitation and excitation and hallucination. So it's a running in the emergency department here and there. When they get out of the ambulance, they would, it's running here and there in the emergency department and agitated. And one child gave me the history. They brought the unripe fruit of datura, and they extracted seeds and grinded it and drink with milk. Why they did it? They just to get a fun to celebrate the festival. That is one of the rare presentation here. So
I think, yeah, datura is a beautiful plant, beautiful flowers.
yeah.
Because I have seen datura and played with datura's seed as well. Beautiful plant. But here the analogy,
Mr. Junja, we need to go to Nepal together and have a taste.
No, from UK, you can have a magic mushroom and datura have got almost the same symptom and sign. So you don't have to go to Nepal. Have a bit of mushroom from the garden. But datura is a beautiful plant. I would love to grow in my garden.
Another plant is mushroom. It's it's a wild mushroom, not in the is a farm or cultivated one. Wild mushroom is generally the farmers who live in the remote area, they pick up in the forest, and accidentally they got this very severe liver toxicity.
Yeah, absolutely right. Yeah. But the hallucinogenic effect are almost the same as the datura. They do the same sort of dance and everything. Excellent.
So
and the other poisoning is I don't know what in English called auk. They call it auk, which has got a small white flower, and in the middle there's like a little things like in the middle. So that's if you pluck it oozes milk, white sort of secretion, very thick, sticky white secretion.
What is oak?
Auk is auk. I don't know what in Nepal called. It's called auk in Urdu or Punjabi. So that's quite potent poisoning. Huh?
I think it's Asura in Nepali. It looks like.
Yeah, you're right. Yeah.
Yeah.
Again, that's a very beautiful plant. It make little like circular set of oval set of pods, and then it's split, and there comes like a feather set of stuff which the seed fly away. I mean, these are a lot of poisoning plant out there.
The one notable finding in 1 year data that we are not getting any patients of morphine or morphine overdose here. So opioid toxicity, we are not seeing any patients here. Probably the government has making a very strict regulation to get the opioid related drugs without prescription. So that may be the reason, but we are not getting any patients in this last 12 months. It's opioid toxicity. In the hospital due to accidental overdose, but it is reported from the community.
Yeah, you're right. It's very common in UK, opiate toxicity, and very common in Pakistan as well. It comes out from Afghanistan, and people take opium and heroin and stuff. Very common there as well.
Kathmandu, while I was a medical student, I have seen this people used to ingest and take heroin, and it's illegal, but they used to take by illegal routes. But it has not been reported here in last 1 year, 12 months.
Very good, excellent.
I think we are eating into the tea break. Already had.
So who is the next speaker?
Is that 11, isn't it? There's a tea break.
The next speaker is Suchit.
Well, thank you very much for giving me.
Thank you very much, Professor.
Oh, they were very informative. Thank you very much, because we have become a bit nostalgic now. So you have reminded us the old past days.
Second back. Rosina. So where are others? Are they in duty?
Yeah, they are on shift or night.